Today we're going to review acute lymphoblastic leukemia. This type of cancer being the most common type of cancer in the pediatric population. To understand the topic, we're going to review the hematopoiesis. This process is the end result of all of our blood cells. This process begins in the bone marrow with our hematopoietic stem cell. This cell can become a myeloid stem cell or a lymphoid progenitor cell. The myeloid stem cell results in the erythropoiesis with the end result mature form of erythrocytes. These cells carry oxygen. Also, we have the thrombopoiesis. Megakaryocytes divide into platelets. These all are important for platelet aggregation and prevent our blood to bleed. Also, we have granulocytopoiesis, giving us the granular cells participating in immunitary response. This group of cells includes eosinophiles, basophiles, and neutrophils. This myeloid stem cell gives us the monocytopoiesis, which begins with the monocyte. This monocyte eventually develops into macrophages, relevant for immunitary response and phagocytosis. Also, we have the lymphoid progenitor cell, the lymphoblast being the immature form of the lymphocyte. The lymphocyte can be a natural killer cell, a T cell, T helper, or T cytotoxic cell, and the B cell. This B cell transforms into a plasma cell. This process is going to be an acute disease because it's going to be a fast and accelerated growth of these cells. Lymphoblastic meaning the lympho group of cells, and blast meaning this group in an immature form of the cell. Leukemia meaning affecting the white blood, not the red blood, meaning erythrocytes. So, acute lymphoblastic leukemia is a dysregulated growth of white blood cells in the bone marrow. So, why people develop acute lymphoblastic leukemia? There are a lot of factors that can participate in the development of this disease. There is evidence that genetic translocations are one big reason on the participation of the development of leukemia, right? So a translocation, it means that a portion of a chromosome it's translocated in another portion of another chromosome. This translocation generates another production of another group of protein or type of protein, giving us the accelerated growth of this group of cells. In children's, we have the translocation 1221, which has a better prognosis. And also we have the translocations 922, which has a worse prognosis and it's more frequent between adults. This translocation is also called Philadelphia. Why? Because it gives us a gene called BCR-ABL. This gene what does, or the way that generates leukemia, it's by increasing the DNA replication, thereby increasing the cellular division and growth. Also, it's going to be more frequent between boys and girls. And per every 100,000 people, 4 of them can develop acute lymphoblastic leukemia. And from this group, 85% of them are going to be children. So it is by far more present between children, right? Also, we have peaks of incidence of the presentation of acute lymphoblastic leukemia between 2 and 5 years old and after 65 years old. Another factors that can participate are radiation, chemotherapy exposure, infection by HCLB1, and genetic instability like trisomy 21, Blum syndrome, ataxia telangiectasia, and also neurofibromatosis. So, to understand the pathology, the physiopathology of acute lymphoblastic leukemia, we need to understand the principles of cancer, right? Um, let's suppose that this is going to be a lymphoblast. So it's an immature cell, but this cell it's going to have a nucleus. This nucleus it's going to have a genetic material. Uh, this genetic material is going to be relevant for the production of proteins. Also, we're going to have this cell growth factor receptors that can be activated and generate a cascade with transmembrane proteins to activate transcription factors. What the transcription factors activation does is that they start reading the genes, right? And they read it and they can form proteins by doing this, uh, thereby initiating the releasing of proteins that can induce the cell into the G1 phase in the cell cycle. These proteins are cyclins and CDKs. Also, we're going to have another types of proteins that can induce uh, proteins for cell arrest. So, stopping the cell to grow, right? And also, we're going to have proteins for repairing the DNA that it seems to be damaged, right? And also, we're going to have proteins that can induce uh, the apoptosis, so cell death, right? The thing with acute lymphoblastic leukemia is that there are multiple steps in which this immature cell can continue to divide itself even when it's not mature. And how it does it, it's by with uh, mutations that gives us another conjugation of proteins and induce the cell to start the cell cycle in the in the G1 phase, or, and not stay in the quiescent state, right? This is why we have deaccelerated growth of immature form of the lymphocells, right? Lymphoblast. Okay, so how are we gonna see it in our patient? Our patient can have, besides the age, right? We can suspect it in children's and also in elderly people, um, but not excluded other groups of adults, right? We're gonna have a high production of lymphoblasts. This lymphoblast it's immature, right? So the function is gonna be decreased. Thereby, the patient is gonna be immunosuppressed. So it's more prone to infections, respiratory infections, and UTIs. Also, cellulitis. Also, we're going to have a decrease in the red blood cells or erythrocytes. Why? This is going to be a cause of redistribution of the energy that is going to be taking the lymphoblast to divide itself. It's like if it steals the energy from all the other group of cells, right? The This is gonna see clinically as anemia and fatigue, dyspnea, decreased saturation of oxygen, and the pallor. Pallor is an important sign in the uh, child with acute lymphoblastic leukemia. Also, a decrease in granulocytes with a decrease in immunitary response and a decrease in platelets, giving us easy bruising on our patients and easy bleeding. Uh, Also, this is important in the suspicious of acute lymphoblastic leukemia. There is going to be also an increase in the bone marrow because it's going to be an expansion by the highly proliferation of these lymphoblasts, giving us bone pain. Okay. Also, we can get lymphadenopathy, hepatosplenomegaly, which is gonna be referred by the patient has abdominal fullness. Also, splenomegaly and thymus enlargement when we're talking about a lymphoblastic T cell leukemia, right? This enlargement in the thymus can be seen as dyspnea, as dysphagia, and syndrome of vena cava by compression of the vena cava. Uh, High key points in the suspicion of leukemia, right? We're gonna have the pallor in your skin, in your patient, the fatigue, of course, the dyspnea, the easy breathing in your patient, and also the bone pain. It's gonna be high and relevant uh, sign in acute lymphoblastic leukemia.